welcome back to the channel. If you are new here, then hi, my name is Brittany and I'm a nurse practitioner. I'm also the creator of the Brittany Holzbeck NP Review. It's the most comprehensive, affordable, and it is accredited nurse practitioner boards review on the market. If you've been staying kind of like up to date with me, you know that I just went through re-accreditation through the AANP, and so I updated my entire course. It is accredited. It's 17 continuing education credits, of which 2.2 of those are pharmacology. Since I went through and updated my review course, I decided it would be a good chance to put an updated kind of like sneak peek of the review course here on my YouTube channel. So I went through all of the lectures. It's over 14 hours of lecture, the entire course. I went through and picked out some topics that I thought would be interesting to include here, just to give you an idea of what to expect with the review course, and also just as a free study resource. So that's what this video is going to be. It is literally excerpts from the review course. So it kind of jumps from topic to topic, and that's just because I really just spliced it all together. But hopefully, nonetheless, you find it helpful. And if you would like to purchase the entire review course, then definitely go ahead and visit my website, www.thenewNP.com. Also, if you ever have any questions, you can always reach out to me directly at npreview@thenewNP.com. But all right, before we just get right into the content, if you could go ahead and like this video, subscribe to the channel. It is a free way to help me out and helps me to continue making content just like this. But all right, let's just dive into the topics. All right, so first up, we're going to be talking about osteoporosis. So osteoporosis is a leading cause of morbidity and mortality in the elderly populations. So it is less common in men than women, but still over 8 million men in the US do have low bone mass, or also known as osteoporosis. So osteoporosis is characterized by low bone mass, structure disruption, and increased skeletal fragility. And this results in decreased bone strength and increased risk of bone fracture. Osteoporosis has no clinical manifestations until there is an actual fracture present. These patients, they don't come into you reporting feeling, oh, I feel like I have decreased bone mass, but they are in fact much more prone to injury and fracture. And so what you might end up finding is that the traumatic event that they come into you with that caused some fracture wasn't really that traumatic, and you find maybe yourself even surprised that it indeed caused a fracture. So this is the type of scenario that can occur when patients have osteoporosis. Not that big of an incident, but a big injury. In patients that have diagnosed osteoporosis, treatment is indicated. So first we need to know, how do we officially diagnose osteoporosis? So a clinical diagnosis of osteoporosis can be made in the presence of a fragility fracture. So this is particularly at the spine, the hip, the wrist, humerus, rib, or the pelvis. And so you might be asking, what defines a fragility fracture? So a fragility fracture, this is a fracture that occurs either spontaneously or from minor trauma. So like what I was just talking about. Another method for diagnosis of osteoporosis is going to be by using the dual energy X-ray and calculating the individual's T-score. So what a T-score is this measures a person's bone density and then compares it to a healthy adult bone of that same gender. So the T-score, this represents the number of standard deviations that the patient's score is either above or below the average. So a T-score of negative 2.5 or less indicates osteoporosis. And this is saying that the person's T-score is 2.5 standard deviations below average. And then of special note too is a T-score of negative 1 to negative 2.5 indicates osteopenia. So to repeat, if a person's T-score is 1 to 2.5 standard deviations below average, this indicates osteopenia. And now these numbers and cutoff values, I would recommend that you highlight and remember because it could pop up on a question. Another method for diagnosing osteoporosis is determining a person's risk for fracture in the next 10 years. So if a patient has a 20% or greater risk of having a major fracture to the spine, the humerus, the forearm in the next 10 years, or If they have a 3% or greater risk for experiencing a hip fracture in the next 10 years, this would be also sufficient enough to make a diagnosis of osteoporosis. And of course, now you're wondering, how do we determine a person's risk for a fracture in the next 10 years? Well, we do have a very easy to use tool, the Fracture Risk Assessment Tool. It's also referred to as FRAX, F-R-A-X. And this calculates the patient's risk for a fracture in the next 10 years. There is a link on the screen. I do encourage you to check it out later. It's a screening tool, evaluates person's risk factors. So it does look at things like whether or not the person is considered advanced age, if they've had a previous fracture, if they are receiving glucocorticoid therapy, if they have parental history of a hip fracture, so a parent, if they have low body weight, if they are a current cigarette smoker or have excessive alcohol consumption, and then whether or not they have rheumatoid arthritis. All of those are risk factors that the tool uses to evaluate a person's risk for fracture in the future. All right, so that was diagnosis, but we need to know about treatment. As always, we always want to be discussing lifestyle measures with our patients. And really, these measures should be discussed before an actual diagnosis of osteoporosis occurs, with the idea that maybe we can help reduce or prevent bone loss. So lifestyle measures should be included in our education with our patients, and we should be talking about intake of calories, adequate intake of calories, and this is because we want to avoid malnutrition, sufficient intake of calcium and vitamin D, regular exercise, strength training, smoking cessation if that's applicable to the patient, counseling on fall prevention. So what ways can we help to prevent falls? A big tripping hazard is rugs. That's something we can educate on. And then avoiding heavy alcohol use, because again, if they're intoxicated, they are more prone to fall and injure themselves. So who requires pharmacological treatment? So individuals who are diagnosed with osteoporosis, either based on a fragility fracture, a T-score, or a risk for fracture in the next 10 years, plus any patients that have been diagnosed with osteopenia who also have a high risk for fracture, all should be treated. And then just a quick backtrack. Osteopenia, remember, this is reduced bone mass. It's less severe than osteoporosis, but it is still significant enough to indicate treatment. And then, so the T-score indicating osteopenia is -1 to a -2.5. And then again, that's plus if they have that risk for fracture. And so we would be using the FRAX tool for this population to determine their risk for fracture. For medication, first-line treatment is generally the bisphosphonates. So for example, we have alendronate or risdronate. Most frequently used would be the alendronate because this has shown to be more effective at reducing both the vertebral and hip fractures. And what these do is these drugs work to reduce bone breakdown by slowing down the activity of the osteoclast cells. So if you remember way back, osteoclasts, they work to break down bone and initiate normal bone remodeling. And so this drug class slows that process down. It is important to note that with the bisphosphonates, this drug is contraindicated in patients that have esophageal disorders. So this includes strictures, varices, Barrett's esophagus, or if they are unable to sit upright for at least 30 minutes. Also, it is contraindicated in patients that have severe kidney impairment or a creatinine clearance of less than 30. So that would be important to be familiar with as well. So anemia of chronic disease, this is also referred to as anemia of inflammation, and is characterized by low serum iron, normal to increased iron stores, and then evidence obviously of inflammation. This type of anemia is normocytic and normochromic, and it has a low reticulocyte count. So remember, reticulocytes are red blood cells that are still developing. So in this type of anemia, the red blood cells are dying faster than they're able to be produced, which is also known as hypoproliferative. So anemia of chronic disease is the second most common form of anemia, obviously following iron deficiency anemia. Typically, what's going on with these patients is they have some sort of underlying inflammatory disease. And so in that circumstance, you should, if they have also an underlying inflammatory disease and anemia, you should suspect anemia of chronic disease, especially like if they have some kind of acute or chronic infectious process going on, some kind of inflammatory disorder, malignancy. And then again, on their lab work, they also have a normocytic, normochromic anemia. The anemia of chronic disease or inflammation should be high in our differential. So common underlying disorders include autoimmune diseases such as rheumatoid arthritis, inflammatory bowel disease, also congestive heart failure is on there, COPD, advanced kidney disease, also infection, again, like our HIV patients, or endocarditis, and there's lots of other causative infections or autoimmune that can cause this inflammatory anemia. These patients, they need to be managed, of course, too, by hematology, and their preferred treatment is really based on whatever is going on with the underlying inflammatory disease. Again, with these patients, iron supplementation is actually reserved for those who have coinciding iron deficiency anemia, because they can have both. They can have anemia of chronic disease or inflammatory disease and also iron deficiency anemia, in which case when that's present, when they also have that IDA, then yes, we're going to supplement them with iron. It's less common, but it is possible, and in that circumstance, that's when you would. Otherwise, we're really trying to treat whatever is the underlying inflammatory process going on with these patients. And then I got another fun little memory trick to help you remember anemia of chronic disease, and it's the phrase, normally inflammation leaves redness. Normally for normocytic and normochromic, inflammation because it is an anemia of inflammation, and then leaves redness to help you remember that this type of anemia has low reticulocytes. All right, so patients with the Helicobacter pylori or H. pylori infection, they're often asymptomatic. However, some do develop dyspepsia, abdominal pain, and bloating. Diagnostic testing for H. pylori can be done with endoscopy, urea breath testing, stool antigen testing. All of those are options for diagnosing an active H. pylori infection. Endoscopy is going to be appropriate if the patient would benefit from having a scope done as well, so if you're looking for something else. But otherwise, like urea breath testing or stool antigen testing, it's more commonly used because it's less invasive. All patients with evidence of an active H. pylori infection need to be offered treatment, and the options are listed here. So there's a couple different, and it's a lot of medication. So there's the bismuth quadruple therapy. This is recommended as initial treatment in patients with risk factors for macrolide resistance, which, let's be real, that's majority of us, because we have used and abused our macrolides. So according to the literature, prior exposure to macrolide therapy at any time for any reason is considered a risk factor for macrolide resistance. I thought that was so funny when I read that, because that's basically everybody. Anyone that's been exposed at any time for any reason. Like, hello, a Z-Pack? I feel like that's been just given out like candy these days. So the bismuth quadruple therapy includes bismuth subsalicylate, metronidazole, tetracycline, and then a PPI, which is given over 14 days. A way to remember the bismuth quadruple therapy is the quote, and this is my little memory trick, when you have a BM, you need TP. When you have a BM, like a bowel movement, you need TP, like toilet paper. Definitely not cute, but it should help you to remember the BMTP. So the bismuth, the metronidazole, tetracycline, and then the PPI. When you have a BM, you need TP. For patients without risk factors for macrolide resistance, which is like who, there is the triple therapy with the PPI, amoxicillin, and then clarithromycin. If the patient has a penicillin allergy, then you can substitute the amoxicillin for metronidazole. And then for patients that have treatment failure with one of the antibiotic courses, then an alternate antibiotic regimen should be attempted. And so you would choose just another regimen that's listed here. It is estimated that up to 20% of patients will fail their first regimen of antibiotics, so testing for cure is extremely important. And this can be done using, again, the urea breath test, stool antigen testing, or endoscopy. Again, the choice of upper endoscopy is really only appropriate if you're doing it for some other purpose as well, like if you're doing a follow-up for like a bleeding ulcer or something. Test of cure should be performed at least 4 weeks after completing antibiotics, And ideally, the PPI needs to be held for 1 to 2 weeks before testing, and that's to reduce the likelihood of a false negative. In the circumstance of 2 unsuccessful courses of antibiotics, a culture with antibiotic sensitivity should be done. All right, so atrial fibrillation. This is the most commonly treated cardiac arrhythmia. It's typically associated with irregular ventricular rhythm with the absence of P waves. Complications of atrial fibrillation include a risk of thromboembolism, including stroke, and the risk of heart failure. AFib is classified by the persistence of the arrhythmia. So there is proximal AFib, and this is defined as AFib that terminates spontaneously or with intervention within 7 days of onset. There's persistent AFib. This is defined as AFib that fails to self-terminate within 7 days. Episodes often do require pharmacological intervention or cardioversion to restore the patient to sinus rhythm. Long-standing persistent AFib. This refers to AFib that has lasted more than 12 months. And then finally, there's permanent AFib. So this is a term that we use to identify persistent atrial fibrillation for which we've made a joint decision between the patient and the provider that they are no longer going to pursue any kind of control for their rhythm, a rhythm control strategy. In some cases, AFib is triggered by another acute medical diagnosis. So remember back when we talked about in the endocrine lecture, hyperthyroidism? This can actually trigger an episode of AFib. And so that is something that we want to be looking into. We want to be looking at for any thyroid disease. Other possibilities include pulmonary embolism, myopericarditis, pneumonia, or a result of cardiac surgery. So there sometimes can be an inciting factor. Classic symptoms of a person with AFib include palpitations, tachycardia, fatigue, weakness, dizziness, lightheadedness, reduced exercise capacity, or mild dyspnea. However, occasionally patients are going to be discovered to have AFib incidentally while doing, say an EKG for some sort of surgical clearance. Patients with AFib, they oftentimes can be managed outpatient. However, indications for a referral to the ER or the hospital would include if they are hemodynamically unstable, if there is a suspected or confirmed, obviously, myocardial infarction, suspected or confirmed heart failure, if it's extreme and uncontrolled tachycardia, or if the patient is severely symptomatic. So as far as pharmacological management goes, if there is an identified trigger, again, such as like hypothyroidism, we need to treat the underlying issue. Often, if AFib is a result of some sort of inciting factor, and if it's appropriately managed, they will not experience another episode of the arrhythmia. Long-term management of AFib often does include an oral anticoagulant, and this reduces the risk of thromboembolism by almost 2/3. On the flip side, though, the anticoagulants do obviously carry a risk of bleeding. So when determining which patients would benefit from the oral anticoagulants, research suggests using the CHA2DS2-VASc scoring system. So what this is it looks at, does the patient have congestive heart failure? If so, they get 1 point. Hypertension, 1 point. 75 years or older, 2 points. Diabetes, 1 point. History of stroke or a transient ischemic attack, 2 points. If they have vascular disease, meaning prior MI, peripheral artery disease, 1 point. If they're 65 to 74, they get 1 point. And then female gender in itself gets 1 point. So there's a maximum score with the CHA2DS2-VASc of 9 points. Chronic oral anticoagulants are recommended in males with 2 points or higher and in females with 3 points or higher. Also, for males that score a 1 and females that score a 2 based on their gender, because remember, females get a point, or if it's based on 65 to 74, long-term anticoagulation is also recommended for these patients as well. The choice of anticoagulants includes direct oral anticoagulants, also referred to as DOACs, or the vitamin K antagonist we know as warfarin. So for most patients that have AFib and an indication for anticoagulation, the literature recommends that we use a DOAC, so a direct oral anticoagulant, rather than using warfarin. However, due to compliance or cost, sometimes warfarin is still used. Also, an important to note is that warfarin is first choice for patients that have a mechanical heart valve. And anyone that has a mechanical heart valve, they're not using those direct oral anticoagulants. Warfarin is used. Otherwise, we prefer those DOACs, but they are very expensive, and so it's not always feasible with all of our patients. So examples of direct oral anticoagulants, we have the direct thrombin inhibitor, dabigatran, we have rivaroxaban, apixaban. There's a couple different options there. Direct oral anticoagulants, they are an important cardiac drug class. They are used not only in the treatment of AFib, but they're also used for venous thrombus prophylaxis and then also for treatment. They're also used in the treatment of acute coronary syndrome and then also for heparin-induced thrombocytopenia. So for patients starting a direct oral anticoagulant, effective anticoagulation is going to be achieved within a few hours of starting the medication. So that is incredible. There are a few important key points when prescribing DOACs. So first, all oral anticoagulants carry a black box warning that if they discontinue the medication early, it actually increases their risk for having a thrombotic event. Also, direct oral anticoagulants should not be used in patients that have severe kidney disease, if they are pregnant, and then again, important is those patients that have mechanical prosthetic heart valves. In that specific population of patients that have a mechanical heart valve, like I said, they recommend warfarin. So patients that are being treated with warfarin for a prosthetic heart valve, their recommended INR is 2.5 to 3.5. We compare this to patients that are being treated with warfarin for AFib. Their target INR is between 2 and 3. So with the heart valve, it's a recommended INR of about 2.5 to 3.5. You will see in the literature there is a little bit of variation, but the point being is that it's going to take longer for these patients to clot with that higher dose of blood thinner that they're on. So we want them just a little bit more anticoagulated when they have these heart valves. So all combined oral contraceptives contain an estrogen and then a progestin component, and research has shown that women should be prescribed a combined oral contraceptive with 35 micrograms of ethinyl estradiol or less. And so to be clear, that ethinyl estradiol is a synthetic estrogen. Specifically, data has shown even less risk associated with 20 micrograms of ethinyl estradiol. And so often this is a good place to start when choosing the combined oral contraceptive. As always, when we are prescribing medications, it's so important to know risks and benefits. So with combined oral contraceptives, there is an increased risk for venous thromboembolism, especially for those who are already at an increased risk at their baseline. And so the following are considered unacceptable health risks by experts, and they should not be prescribed these combined oral contraceptives. These include patients that are 35 and older who smoke 15 or more cigarettes a day, patients with multiple risk factors for cardiovascular disease, such as old age, smoking, diabetes, and hypertension, patients that have hypertension and a systolic of 160 or greater or a diastolic of 100 or greater, patients that have a history of a stroke, if they have known ischemic heart disease or complicated valvular heart disease, if they have current breast cancer, if they have severe decompensated cirrhosis, if they have a current venous thrombosis and they are not receiving anticoagulation, if they have hepatocellular adenoma or malignant hepatoma. This is benign or malignant tumors of the liver. If they have a history of migraine with aura, and then finally if they've had diabetes for more than 20 years, or if they have diabetes along with nephropathy, retinopathy, or neuropathy. And so you can see there is a lot of components there to consider before we prescribe these combined oral contraceptives, and so it's really going to require proper screening on your part. If the patient has decided to start birth control, they can be started at any point in the female's cycle once, of course, we have successfully ruled out pregnancy. When a new form of birth control is started, you should instruct the patient to use a backup form of birth control for the first 7 days. Combined progestin estrogen can be delivered in a transdermal patch, which is changed weekly, or a vaginal ring, which is changed monthly. If the patient is using the pill, there are some important education points regarding if they miss one or more pills. So if one single pill is missed, then that patient should take the missed pill as soon as possible, even if it means that they take 2 at once, and then they would just carry on with that normal 1 pill a day regimen. If a patient misses 2 of their birth control pills, then that patient should be instructed to resume the 1 a day scheduling and use a backup form of birth control for 1 week to prevent unwanted pregnancy. So it's kind of like they're just starting over if they miss more than 1. Also, like I mentioned, there are other benefits to combined oral contraceptives aside from its use as a contraceptive. One benefit is that these agents are quickly reversible. So if the time comes that the patient wants to conceive, it's an easy transition for them. Also, these medications can help to regulate blood loss, decrease blood loss, improve symptoms of dysmenorrhea, and has even been associated with reducing the risk of ovarian and endometrial cancers. So yeah, there are risks that need to be concerned, but there are also some clear benefits with these combined oral contraceptives. All right, and then on the screen here is a little memory trick for you guys to help keep the contraindications to combined estrogen, progesterone, oral contraceptives straight. Hopefully it can help a little bit. And it's the word bold chimes. So BOLD chimes, CHIMES. And so it stands for breast cancer. O is for 35 and older that smokes 15 or more cigarettes per day. L is for liver cancer or cirrhosis. D is for diabetes for greater than 20 years. Starting with chimes, the C is for the CVD risk factors. H is for hypertension with a systolic of 160 or greater, diastolic of 100 or greater. I is for ischemic heart disease. M is for migraine with aura. E is for embolism or thromboembolism. And then S is for stroke. Hopefully that helps you. I know it's a lot, but there's so many contraindications that I wanted some kind of memory mnemonic that could maybe help a bit. All right, and so it's important to also be able to differentiate between specificity and sensitivity. And I know that I've covered this a few times throughout the lecture when it was applicable, but I just want to kind of hammer it home one more time. And so I will go over what these mean and then a memory trick to help you get these straight. So specificity, this is the ability of the test to correctly identify individuals without the disease. And so I remember this with the phrase false truth, because remember, in specificity there is an F and a T. False truth, it correctly tells you the diagnosis is false. Sensitivity is the ability of a test to correctly identify those with a disease. And so remember the phrase true truth, because there are 2 T's in the word sensitivity. The test correctly identifies those who truly have the disease. All right, well, hopefully you found that helpful if you are studying for your nurse practitioner licensing exam, or if you just wanted a little refresher. Either way, hopefully you learned a little bit. Again, remember, if you're interested in hearing the full review course, then go ahead and check out my website, www.thenewnp.com. Everything is there, including my complete review course, but I also have lots of other study resources there for you as well. So definitely check it out. I also have it linked in the description box below. But other than that, I wish you guys nothing but the best. Don't forget to learn something new every day, and I will talk to you guys soon. Bye, guys.
I've climbed the mountains in Montana, danced in the lights of New Orleans. Portland ran away with me, and San Francisco stayed with me. Nashville made its way in between. Fell in love in Minnesota, fell apart south of Salt Lake. Colorado calls to me, and Washington will always be begging for a piece of me to stay. Maybe some things never change, but I wanna know how it feels to hang pictures on a wall